You're listening to Community Health Watch on WNHHLP 103.5 FM, New Haven's home for community radio. Insightful conversations, impactful ideas, and voices shaping our community and beyond. Let's begin the dialogue.
Good morning, everybody. I am excited about today's show. I am the Reverend Eldren Morrison, the pastor of the Shaw Temple AME Zion Church in Smyrna, Georgia. But of course, we love New Haven and all surrounding communities. And this is YCCI, Cultural Ambassador Community Health Watch show. I have a co-host this morning, and we're delighted to have him. I'm going to allow him to introduce himself before we introduce our guest.
Oh, yes. Hi. And thank you, Reverend Morrison. I'm Dr. Leroy Perry, pastor of St. Stephen's AME Zion Church in Brantford, Connecticut, and a cultural ambassador for the last 15 years, former director of the Fatherhood Initiative Program in Connecticut, and I serve on the OIC board in Waterbury. So I'm really glad to be a part of this show. I think it's going to be challenging and interesting and informative. And I'm just happy for our guest, who is Dr. Jordan, who's going to be with us.
Yeah, Dr. Perry, you are right. Just yesterday, I was at dinner with one of our bishops, and we were talking about mental health, and particularly clergy and mental health. But then it broadened to the community and our parishioners, and let them know that we were having this show this morning. And I'm excited about our guest as well, because I know her and her family so well. And I want to allow Dr. Samantha Jordan to take a moment to introduce herself to our community.
Thank you all for having me on the show. And my name is Samantha Jordan, and I'm a licensed psychologist in the state of Georgia. I have been licensed since 2012, after many long years of undergraduate and graduate schooling and training opportunities along the way. I have a solo private practice in Douglasville, Georgia, that was launched in May 2023. So grateful to have Pastor Morrison come to the office with my family to pray over the space and to kind of make it ready to be accepting clients and for good work to be done. And I'm thankful to the Lord that He has helped the calendar get full quickly and stay full for these past almost coming up 2 years now.
It doesn't seem like it's been that long.
It does not. It certainly does not.
Dr. Jordan, can you talk about how you got into the field of psychology? Because growing up, I didn't see many people who looked like us in this field.
No. I did not either. Probably like a lot of people who entered this field, I had been told that I was a good listener, and I gave good advice, and that I helped people to feel calm. And I thought, well, what can I do with that? And my mother had taken a high school psychology course, and that's all she would talk about is how much she enjoyed that class and how she wished that she had had the opportunity to go on to college and perhaps have a career in psychology. So that, became my major and my undergraduate major. And, once I got to college, I realized, psychology is more than just talking with people and listening and giving what I thought was advice. I learned that it's not advice giving, because that would just come from, my limited experience and how I could help people. But it really comes from guiding people and kind of having that theoretical and evidence-based background behind the ways in which we can help people through different therapeutic modalities. It was also in college that I got my first taste of psychological testing. And that really sparked the passion that I have for assessment today. And I knew after graduating from college that I could not go on to practice psychology if I was not ready to go on to graduate school. So there was no break between the end of undergrad and the start of graduate school, except that 3 month time period from May to August of the same year, where I started my graduate studies at Georgia School of Professional Psychology, which was folded into Argosy University while I was a student there. So after 4 years of undergrad and 7 years of graduate school, including a stint in Huntsville, Alabama, to complete my clinical internship before I graduated. Then I had that doctoral degree in hand. So it's a doctorate of clinical psychology. And my program was one that focused on the scholar practitioner model, which is not as much of the research base as we might have in different PhD programs, but more of a focus on understanding the research that's kind of already been out there, and a focus on being someone who is trained to be a practitioner once we have graduated from the program. So I felt very prepared to enter private practice. It was not quite the area that I thought I might enter in. I thought I might see myself working in a hospital setting with brain injury patients, as my focus is clinical neuropsychology. And I do get to dabble a little bit in that with my assessment work that I do with people with brain injuries, either acquired or organic, born with, but just in a private practice setting.
Yeah. Could you talk a little bit about, especially with private practice, and being in the community itself, some of the, I guess, the stigma is associated with, particularly our people, Black and brown people, seeking help in the area of mental health?
Yes. Probably what I've heard the most is that crazy people come to therapy. And if people have delayed getting the help they needed, it was usually because they didn't want to be seen as crazy or as not being able to handle whatever life was throwing at them. Definitely I have probably seen more of Black and brown folks and people who look like me since being in private practice. I spent the first 12 years of my career working in a group private practice as the only African-American practitioner there, the only one of color. So when people would ask for someone who looked like them, I usually got them. But I think that has been probably the thing that I've heard the most from people, is that they don't want to seem weak, or that they thought, well, what does it mean if I go talk to someone? What's that going to help? It's just me telling my problems to somebody else. So I think people, in our community do have an idea that, well, it's just talking, and talking doesn't help. And if I've gotten along this well with just keeping it to myself, why wouldn't I keep doing that? And I remind people that we're vessels, and any vessel can overflow when you have too much. So if it's too much sadness, if it's too much hurt, too much anxiety, too much trauma, it is going to find its way up out of us.
I definitely have heard some of the same things, particularly in religion. You hear, or faith, the faith community, you hear, well, if I'm talking to Jesus, why do I need to talk to someone else? Well, could you talk about some of the common mental health challenges that you see in our community, and are they affecting right now? Are they affecting more men than women, or children, or seniors? How do you see this playing out?
Probably what I've been seeing a lot from people is depression, anxiety, post-traumatic stress disorder. And, surprising a little bit for me in people who are about my age or younger, who have had such just horrific past experiences in their life with abuse, you know, even witnessing something that might have been abusive or life threatening to someone else, and, you know, that they've carried it, you know, all through their lives until now. That, and I'm seeing a little bit more learning disorders than I have before. And certainly I see it a little bit more in parents who are bringing their children in for testing, because many times they are coming for an educational reason. But I've had a few more adults lately who have either been diagnosed with a learning disorder in their childhood, or they weren't diagnosed, but they know that they struggled. And those struggles have stayed with them today, with the inability to get a job or keep a job, or at least get one that can support their families well. Or people who are, you know, they've had some emotional turmoil around not being able to read well. And they've gotten to be, you know, adults with their own children, who now they're struggling to help their children because of their own learning disabilities. And I'm sure it's happening across the board. I'm probably seeing more women. I will get calls from men who are seeking their own therapy. And, you know, maybe it's a fortunate kind of problem to be in, is that my schedule has just filled up for therapy. So, you know, I try to make sure I have good referrals to give to anyone who's still seeking therapy, while it's the testing that I am still able to meet the need of for people by getting them in. But, you know, a few of the seniors that I see are also people who have been dealing with something for a long time. And this usually has been a traumatic experience that even their adult children are kind of just now understanding that this is what their mother or their father went through. And this is why we're still dealing with the repercussions of that. And they may be in their mid 70s and early 80s.
Wow. As you talk, there's so many questions that come up. We might need to do a part 2. I don't know. Dr. Perry,
there's enough for a part 2.
I'm telling you, what are you seeing in the faith community and just, I guess, our community in general in terms of mental health and as a pastor and as a community leader? What are some of the things that you're telling folks?
I think that, you know, I think that the church has been the emergency room for the birth of the church. It has been the emergency room, because when we couldn't go to doctors and we couldn't go to the clinicians, we were taught that, you know, just everything happened in the church, whether you learn to read or write there, whether you learn to do oratory there or to practice in the choir. I mean, it took place in the church. And so that burden of responsibility that the church has been bearing, I think, and with some suspicion with what government had to offer. Like when you were talking about children coming, you know, we've dealt with this even when Morrison was in New Haven, how Black children who had learning disabilities were all of a sudden separated, medicated, and just left out. Yeah. And no one really wanted to look at the root cause or to see how effectively they could deal with it. The other thing that I found interesting was that even when I went to court and there was children and families that were going through stress or mental issues, the parents were looking for a Black clinical psychologist, and there weren't any. I mean, you could count them on one toenail. And it was the same thing in the fatherhood program. We tried to get these men who'd come out of prison, who could not readjust in society, homeless, jobless, frustrated, baby mama drama. So we went to the mental health agency, and there was only one Black clinical psychologist, and he didn't show up. So I mean, it's a big problem. So to see you and to see that you're thriving is hopeful for me and for I guess for those in ministry, because we don't know where to refer people. I mean, we refer them to God because that still works for a lot of people. But beyond that, we realize that you need that flesh and blood individual with the training to help us navigate through some of these difficult waters that we are traversing in right now. And I just, that's why I appreciate you being on the show, and that maybe I'm hopeful that other young people might look at this as a career for them as well. And so, whatever tips we can get from you and whatever sources of information we might draw from you. Like, I would think, in the early church, Reverend Morrison, we used to have a nurses station.
Yes.
And the nurses station was for people who would, at some point get too Holy Ghost and you couldn't help them.
Yeah, yeah.
But now we're trying to bring wellness centers in, and doctors like you who will show up in our church and be available to people, have their services available to people. And I think that's where we're moving, and that's where the cultural ambassadors have been trying to do up at Yale, to bring the medicine and bring the clinicians to where the people are. Instead of trying to, when you say go find a psychologist, how do you do that? And how much does it cost? See, that's the other thing. Does Medicaid or is there any help for poor people who have conditions of mental health? And that's, I think, a systemic struggle that we have to deal with. I remember when there used to be drug clinics and everything, there was money going everywhere for mental health, and all of a sudden it drew up. Just like Donald Trump is drawing up right now. He's erasing that whole budget item line. And so what are poor people to do here?
Hey, Reverend Perry, you're touching on the rest of these questions that are listed, but not to jump ahead.
Go ahead.
But when you mentioned the I guess you're getting to the barriers of what keeps people either from seeking the help or from finding it. And, a big part of that is the cost or a lack of insurance. Or if it's not a lack of insurance, it's a lack of psychologists who accept insurance. There, I won't say that there are not many who do, because there are. Sometimes they're on limited number of panels. So if you have Medicaid in particular, I probably get many calls for folks who are on one of the 3 managed Medicaids in Georgia, Peach State, Amerigroup, or CareSource. And they might say, you're the 12th person I've called. Do you accept it? And I do. And that was a major piece of accepting insurance at all, but especially accepting the Medicaid, because they are the ones who would have the most trouble accessing mental health care, are those who have Medicaid. And, sometimes I feel like it's by design that the companies that administer Medicaid make it difficult, first to get onto the panel for the client, but that they can make it difficult for clinicians to stay on their panels, and not just because of the pay, but just a lot of the administrative hurdles that you can jump through. And I've probably been dropped from a panel accidentally somewhere, somehow, with some computer glitch a few times. And that would, maybe be enough for many people to say, I'm getting off this panel. No more Medicaid. I can do better with Blue Cross or something like that. But I think, it's important that as many people as possible have access. And the only way that we can give that to them is to make sure that we, take the insurance that they have.
Is there for folk who have no insurance, is there a sliding scale? I know it used to be some clinicians would have they would look at the person and they want to help them, but they got to charge them.
Mm.
And so they would put them on some kind of sliding scale. And then the other question
It
is,
still exists.
what happens to do people stay who come to you? Do they come one time and that's it, and looking for a quick fix, or do you find that your patients now are steady?
I
You know,
say
they
yes.
stick with it until they get the help that they need.
I would say that the people that I see for therapy have stuck with me. And, I've kind of been working in their lives with them long enough to have gone through a few different transitions with them, whether it's been divorce or the death of family members, or that I've been with them long enough to see them out of high school, out of college, and out of graduate school.
Wow.
So that's one reason why the therapy calendar for me has not been very open, is because the clients that I have been working with have just stayed. Sometimes I think they might have stayed because they just like talking. They know, I like talking to you every 2 weeks. But the longer they've stayed, the longer that we've gone from periods of quiet and all is well to, we've got upheaval and chaos happening. So I've had clients that have been with me as long as I have been, almost as long as I've been practicing. And I'd say probably 8 years maybe is the longest that I've been working with someone. And then sometimes we do get to a point where we feel like we can terminate treatment. And sometimes they come back because life happens. The people that I'm currently seeing who are my clients that are probably cycling through more are people who are seeking an evaluation of some sort. And that's probably about 3 to 5 appointments. And then, I'm able to offer them referrals to people that I trust if therapy is what they need. And I know that might not be an area that I have an opening for them.
Dr.
So
Jordan,
I try to keep my referral list active and checking on that to make sure the people I refer them to still have openings.
Dr. Jordan, could you talk a bit about, you talk about referrals and things. I remember Dr. Perry saying something about in New Haven. I remember the Sunday that I invited a psychologist to come in and just observe service and tell me what she saw while I was really dealing with it in the church. But what is that partnership, or should there even be a partnership between the professional psychologists or the psychology community, mental health community, and the faith community? What does that look like? Because I can tell you now that I talk to folk all the time, and after I talk to them about twice, I'm giving them referrals to you or someone else that we know of. I don't even know if that's the right thing to do, but it's what happens. Should there be a rapport? Should pastors be involved in this work? What are you thinking? What do you think?
I think pastors and other church officials should definitely be involved in helping the access situation. I think our faith informs us that God works through the hands, the mouths, the thoughts of the helping individuals. And I'm pretty sure many people think that in the field of psychology, that what they're doing is a calling. But we know that we can't do this work by ourselves when we know that there are communities, one of which is the faith community, that can help people to know that we are available. And I think that faith leaders can help with reducing the stigma and the shame that can surround mental health problems. Sometimes, of course, people may not know I know I've got depression, but they know I don't feel good. And I think we want them to be open enough to come to, someone like you or Reverend Perry and say, I don't feel good. And by your questioning, you can, in your wisdom to know, this sounds like depression.
Okay.
And then the openness to, even have people talk with you, it could be the little bit that they say, can help them to know that, oh, it was okay to do this. And I didn't only get from Pastor Morrison that I just needed to go home and pray, or that they were going to put my name on the prayer list. That he said this, but he also said, let me put you in touch with Dr. Jordan, or, someone else within our Reverend branch. People who, we may not be the ones that will actually do the work with the client, but we at least can know, talk with them and see, well, who do I think would be a good fit to work with this person? So that the church still ends up being the place where people can go to get the process started.
Yeah.
Dr. Jordan, let me just say this. I think that's a marvelous idea, and I think that this is a great opportunity for Reverend Morrison and you to bring about a real significant change. You see, when Reverend Morrison mentioned that he had met with some ministers who were dealing with this issue, because ministers think they're next to God and they don't need the help either. So maybe this is a two-part phase where he can invite ministers to come in so they'll know. This is what we do with cultural ambassadors. We meet with researchers and then we go back to the community, because there's still some ministers, I believe, who think that it's either too expensive, it's not relevant, it doesn't work, it's, God is all we need. And they need to hear from people like you and who've helped other people who have their stories that you can share without giving the names, but just share that these people do get help. People who've gone through trauma, people who've gone through addiction. I mean, sometimes you don't need somebody in your family. Sometimes you need an independent person who can help you. And then the other thing is that once the ministers get trained, then the people, maybe the ministers can bring that to the churches, and we can have a hotline where folk who may think they need but are not sure can have that kind of private conversation. I'm dealing with something. Mama is giving me hell. I'm about to kill her.
Don't be a flag. Yeah. Need more than prayer. Good idea, I think.
Yes.
Dr. Jordan, could you talk about some of the, I guess, the warning signs, as Dr. Perry just brought that? What are some of the signs to this is an issue that may be beyond the help or of ministers or just the individuals themselves? What are those warning signs for mental illness?
Yeah. And those are good for us to know, maybe, as we were just saying, for clergy to know, so that they're hearing this from a member, maybe Sunday after Sunday. Eating or sleeping too much is one of those early warning signs, especially if someone has, talked about feeling tired a lot, feeling run down.
Wow.
And if they say something like, and it's not a medical issue, or I've gotten checked out, I've been to the doctor, they said I'm good. Pulling away from people and their usual activities. If there's someone that, if we maybe know that they've been struggling in a way and then we don't see them for a few weeks, then that is, cause for concern, cause to reach out. Someone talks about feeling numb, emotionally numb, feeling like nothing matters, feeling empty. That's concerning to hear. And especially for young people, when I think about depression, for our children and our youth, they may not be sad, and they may not say, I feel sad. What we may see is that they're more irritable. They're, more easily annoyed. They're touchy. They're agitated. And that can be a sign of depression in our young people. Having unexplained aches and pains, feeling achy, hurting. There used to be a antidepressant commercial for Cymbalta, and it would say, depression hurts.
Yeah.
And depression can physically hurt. Sometimes I think it is because people may be spending too much time in bed, and laying too long will make you hurt. But that the senses are more heightened when there is, mental health condition that's present, and they may feel aches and pains and perceive the feeling as hurting more than maybe what objectively does hurt. If someone talks about having thoughts of wanting to take their own life, or feeling like, I think I would just be better off if everyone would be better off if I wasn't here. Talk like that. If someone says, they made an attempt, or people suddenly giving away things that we think, that's very sentimental. Why are you letting this go?
Yeah.
Smoking, drinking, drug use, severe mood swings. If someone's kind of feeling like, I can't get my feelings together. I'm all over the place. I'm up and down. I'm high, I'm low. Flashbacks. If someone is talking about, experiencing thoughts and feelings from the past that they thought, I haven't thought about that in a long time, but now it's all I think about. It's bothering me. It's interrupting my sleep. It's getting in the way of my work. All of those things are, we say early warning signs. Sometimes it could have been happening for a while, but the person just begins to present it in a way that we can see it.
You got a free appointment on your calendar? I like to.
You're thinking the same way I am.
When you went through the list, there were, I could have checked off a few of those boxes. But, I was thinking also people, I had a professor who was talking to me once about stress. And he said, stress is like a rubber band, and it, and as long as it has that elasticity, it's in control. But when it gets to the point where it doesn't come back, he said, that's what you have to deal with. And then he also was talking about, when we were talking about trauma, and in the ghetto, I don't know if we can still use ghetto as a word, in the hood, and where poor people in the projects, where the disinherited might be living their lives, you see, it's there. It's almost hidden, but it's not hidden, because it's like I worked at an alternative school in Waterbury once, and it was amazing that the young kids who came in, their stories, the stories behind the stories. I said, what did your father say? Oh, I don't know my father. Well, why are you always late from school? Oh, because mom's not there, and I can come when I want. So that there's much going on, and there is nobody at the school system that's saying, hey, maybe we should put some this should be a part of our curriculum, that they have some person, not just a social worker, but a clinician, to talk with them about early signs of trauma, early signs of stress. And you know what? When I see dads who are not good dads, it makes me think about whether or not they knew their dad, or whether or not they grew up in a community where the trauma and stress was so much that it carried over into adult life. I don't know if that's a generational cursing or, but it's real. It's real. And now the new study says that 30% of young people don't even want to go to church. So there's something missing in the equation. I don't know how, Reverend, because we're here to try to help people.
Yeah.
And you're trying to help people. How can we help them? We can't find them.
That's right.
Right. You know, that made me think about in my training, in the therapy training that I received, we talked about therapy as a corrective experience for people. And it's, you know, not a substitute for, you know, maybe not having, you know, good, effective parenting. But it is a corrective experience to help the client experience what they didn't have, in the sense of that kind of effective parenting, um, guidance that they may have lacked, and the the security of the therapeutic relationship is what allows that corrective action to happen. If we think about corrective action plans and you get this bullet list of, well, you need to do this and fix this and change this. And the therapeutic relationship itself kind of acts as a corrective action plan. And certainly, you know, for me in working with people for as many years as I get to work with them, that we get to experience that corrective action together. I think there might be one of the questions that we haven't gotten to yet about the benefits of therapy and what people have said has been helpful for them. And a lot of what they talk about is go there now.
What is it? Yeah.
Okay.
Right. Yeah. Yeah.
And people will talk about, you know, how therapy has helped them to communicate better. Yeah, definitely communication is the number one thing that's talked about, because people will enter therapy not knowing how to tell what they need. And I do let people know that, you know, I'm not a mind reader and neither are they. But together we will kind of peel this onion and figure out what it is that we're needing to address. So people will say that they are able to communicate with others better, especially in times of high conflict, when many of us would want to run away instead of let me stay here and kind of resolve this issue and get to some resolution. A greater willingness to see tough times through. And lots of people will come in with, you know, avoidance is something that they've used as a coping mechanism. And, whatever people are dealing with, it comes into the therapy room. And sometimes we're going to reenact that. But if we are reenacting it, it's my job to say, this sounds like what you said has happened in your family before. And this is a space of correction. So we need to recognize it and take steps so that it doesn't happen again, because what's happening in your life or what has happened can't happen in here if you're going to be getting better and taking what you've learned out of therapy and living it in life. Sometimes that's enough for people to know that, oh, I didn't want to have the same thing happening in my life happening here. But that's what we bring to therapy. Less of a tendency to panic when things don't go the desired way. People have talked about that as being the benefits of therapy. Improving the quality of their family, their friend relationships, their work relationships. But maybe most importantly, that they're willing to look inward at what can I change or what can I do differently in this situation. Some people will say, I'm coming to therapy because those other ones won't. And the therapy is right. But the therapy is for them. Yeah. It's like, you're right. You can't change anyone. Your job is not to fix anybody. But if therapy has helped you to deal in a better way with the people in your life who you say won't go to therapy, maybe they need to, then you've gotten the benefits of therapy because you have become changed, even if the people that you deal with don't change at all.
So in that same sort of vein, after a person has come to Dr. Perry or myself or another pastor and say, Pastor, we're experiencing these things, and we sort of recommend them to maybe your practice, what would they expect? They, never had a history with going to any kind of therapy whatsoever, and I'm sure they're apprehensive, scared. What do they expect coming in?
Yeah. I usually will talk with each person who calls me to see if I'm a good fit for what they need and if what they're presenting with is a good fit for what I do. So that I know that I'm not working outside of the scope of my training. Sometimes, particularly when they come from our church, I think about how well do I know this person, and certainly if I have any knowledge about them, we've worked together in some capacity. Those are the clients that I would usually say, let me refer you to someone that I trust.
I see.
So that we, number one, are keeping things very confidential, and that they don't have any, hopefully no concerns that, oh, I talked to Dr. Jordan yesterday. I hope she don't bring that up on Sunday. Right. But if it looks like, okay, we're a good fit and, we don't have a personal relationship already, then they can expect, the housekeeping things that I might say, I'm going to need to know your demographic information, your, address and telephone number, your insurance, things like that. And a lot of explanation I have found is helpful for people who have insurance, but they may not really know, how does my insurance work?
Yeah.
How does this work? What do I pay you? So we talk about co-pays and deductibles, and I try to use the knowledge that the insurance company has helped me to understand about these things with them so that they know that process. But from there, I ask them, what do you hope to get from this? How will you know that you don't need therapy anymore? To get them to look forward to, well, I don't think I'll be needing this anymore if I get this job or if I go back to school or, if we stop arguing so much at home, whatever it may be. So that then we know, okay, this is what our therapy work needs to be working toward. And, sometimes we get off course and, my job is not supposed to get off course with the client. And if I do, I'm supposed to be able to get back on track and to help them, refocus on, is what you're currently doing and saying, even the ways that you're thinking, how is that helping push you forward toward those things that you said that you wanted to achieve? And to kind of keep them moving in that direction. So we talk about the frequency of appointments. Some people will come in and think, I'm so broken, I'm going to need to see you every day.
Wow.
And I said, well, I wish I had that kind of time in my schedule where, but sometimes it is, well, let's meet weekly for a while. And I try to be forthright with people about, this is what I have in my schedule. This is my availability. And for people there are certainly those who do need multiple sessions. And if it even seems like that could be what I'm hearing in that initial appointment, either I let them know I don't have this amount of availability, but I do have this. If you think that you can work within this and that you can be okay on the in between appointments, then let's try it. If they seem like, no, I really do need a lot of intensive whatever, then sometimes they don't need individual therapy at the onset. Sometimes they do need intensive outpatient services, like at the area psychiatric hospitals. So a lot of what I'm doing with people who may, call me or get referred to me is also kind of triaging to see, what is it that you need? And based on what you're telling me, I think you need something more intensive first. And that we can work together, but maybe not before you've had a period where you need to just be stabilized.
How does that conversation go? Because I would think if I'm already nervous and I'm stressed out, I've got people are telling me I might have a mental illness or disorder. And now I sit down with the psychologist who tells me I need something a little stronger. Uh, how do I leave this session?
um, it's always a delicate conversation.
Yeah.
When it is like that. And I try to preface a lot of what I say to people before I just put it out there.
Okay.
Because I do know that if I just put it out there,
yeah,
they will leave scared. They
Yeah.
may say, "Oh no, I knew I shouldn't have done this," and walk out. So I'm always trying to word it in a way where they know that this is what my expertise is telling me, but also that this is what my experience tells me from people who are similar to you. Because I think it is helpful for them to know that you're not the first person that I've met who may have a laundry list of things that are going on in their life that may need something intensive. And I think people are very much helped by the fact that, oh, I'm not the only one. And I do get that question a lot from people is, do you see people like me a lot? Or do you have, do you work with people that's got this? And most times I'm able to say yes. Yeah. There's been the rare occasion where it's like, no, you're the first one.
yeah.
But even then I'm saying, not quite like your situation, but I've had someone that's had something similar, and that is usually the case.
I'm sure you will probably be able to remember times that I've shared with people in the congregation, even in preaching, that, tap your neighbor and tell them you're not the only one. You're not by yourself. Just to give people the comfort, like, wow, I'm not the only one going through this, Yeah.
Right.
Dr. Jordan, let me ask you in terms of your patients, in terms of male, female, older, younger. Right. I was in a counseling program, Foundation for Religion and Mental Health, as a pastoral care counselor. And I had to give it up because it was just, it takes too much time. And it's like you say, sometimes you have to refer people out, and it's just, it's not a quick enough fix for me. I just don't have the time to pastor and to do that. So I really appreciate the work that you're doing. But I've had parents in my church who've said, I can't handle my teenager anymore. And what am I to do? Yeah. And, this is before they were doing emancipating young people and all that. And these kids in Harlem, where I was working, they were no joke. These folk were grown at 12. So, I mean, so in terms of the demographics of your work, do you deal more with women, men, and children, or how does that break down for you?
I would probably say the bulk of my testing practice is children. So elementary through high school age. The bulk of my therapy practice is women.
Interesting.
I was trying to think of demographics, if it's about equally for Black and white with women, and I'm feeling like it's probably skewing more Black and brown for the women that I see for therapy. I have a few men that I see who have been with me for a while, but I've gotten many calls from men as well. So I do feel like maybe more men are more embracing of therapy. Now, probably anyone who calls, they're coming in when they have dealt with it for as long as they could.
Yeah.
So, unfortunately that I'm not able to catch anyone at the first sign that they thought, I think I might need to go see someone. So usually it is people who have felt like, I guess, let me try therapy. I've tried everything else. Maybe this will work. And probably a fewer people that are over the age of 60. But probably the bulk is around the about 30 to 45, that age range of therapy clients that I see. I do see adults for testing as well. And probably not as many as the children, but they're not far behind them in numbers. Many times it is adults who might think, I have an attention problem. And maybe I just have never gotten diagnosed as an adult. Sometimes they do. But what I find is that it might be the attention things that got them in the door. But what we have found is that this is PTSD.
Wow.
This is not, a primary attention problem.
Yeah.
This is years of trauma. That anxiety and depression seem to be the three top ones where people will believe that it was an attention issue, but it's really something very emotional and traumatic.
Let me just say that we're listening to 103.5 FM WNHH New Haven Radio. We have to give a shout out to our sponsors here. Do you deal also with couples, like baby mama drama couples? Like I had people in the fatherhood program, and they could not get together. They needed somebody in between to listen to both sides to kind of help navigate.
That would be one of those areas, Reverend Perry, where it is outside of my scope of practice. But I have a few good clinicians that I refer couples to that I know personally. And, I keep them on my referral list until they call me and they say, hey, Dr. Jordan, I'm full. Don't send me anybody else. But I definitely agree with you that in my work with children, of course, the work is with parents as well. And sometimes those parents either are not always married, or they're not always on the same page when they're married, or one of them may not be in the child's life as frequently as, is needed. But many times the co-parenting therapy is needed. That if the child is going to get better, both parents have to be on the same page. And that's a little bit harder when there's, two different households that the child is kind of going between.
Yeah.
I'm not always sure how many people use those recommendations that I have in the backs of my reports to seek that out for themselves. But I do give the referrals because I think that will help them to not have to find their way to another psychologist only because the same issue is going on, because we needed the parents to be on the same page with one another about their child.
You think we could come up with a word better than mental illness to describe this? I mean, because in psychiatry, that's what they're trying to do now. They're trying to take away all these labels that have stigmatized, like schizophrenia and,
I will at times use the word mental health condition.
Much better.
Because, people don't want to see themselves as sick. Yeah. And if we say mental illness, that, it implies that, I'm sick and, if it's in my head, can I ever get better from that? So mental health condition, I think, could be a term that people are a little bit more accepting of hearing. Many times people will say, well, I don't want to be labeled. I don't want my child to be labeled.
Yeah.
And I understand the sentiment, because we don't want to be seen as the condition that we have. It's a person with diabetes, and people probably like that better than, oh, you're diabetic.
Diabetic. No.
Right. But I do like to let people know, and I can't get away from, if I have diagnosed something, I do let them know this is the diagnosis. And then we talk about what that means. Because they can leave here with a a name on a sheet of paper and think all kinds of things. And I want them to have me explain it to them and use the resources that I might have provided, than for them to take that and put it into Google and come up with all sorts of things about themselves that may not be true about them. So that's where the beauty of the testing results can help us to know, yes, maybe I did diagnose ADHD. That doesn't mean that you can't learn and that other things are wrong with you. It means these things. And here's your data that shows where your strengths were, where your deficits were, and what I think can be helpful for you going forward.
So you do dyslexia as well?
I do. Mm-hmm.
Listen, family, we are out of time, not out of conversation. We need to do part 2 to this, because there's so many avenues and so many questions that our community really does need to hear this conversation we're having. And so we're appreciative to WNHH 103.5 FM for getting this word out, helping us to get this word out. Thank you so much, Dr. Perry, for co-hosting, and thank you, Dr. Samantha Jordan, for being our guest this morning. We have thoroughly enjoyed you so much, and certainly look forward to sitting down again, talking to you sometime. Thank you, everyone.
Thank you.
You're listening to the Community Health Watch Show on WNHHLP 103.5 FM, your home for community radio. Stay informed, stay connected, and take charge of your health. We'll see you again